So the heavier you are, the riskier it is when we're doing a sentinel lymph node biopsy or an axillary dissection, because we know that lymphedema might develop more likely in a patient who has an elevated BMI or who smokes or who's not exercising. Exercise actually does help those lymphatic channels move. You're promoting that movement. When as you're pumping muscles, those lymphatic channels are more likely to have more appropriate flow. Whereas if you're a little bit more sedentary, the risk of lymphedema goes up again. So it's really important to, like we talked about just now, to manage weight, both with an appropriate diet and exercise. And that does, in fact, reduce lymphedema risk. I've seen plenty of patients who have, again, an appropriate BMI who have unfortunately needed to go through with an axillary dissection and lymphovenous bypass and never do develop lymphedema. They just, their BMI is great and they're exercising and they're active. And so it is very telling when I see that. We know that exercise really, truly helps, and keeping an appropriate weight really, truly helps.
Welcome back to Taking Charge of My Cancer, where I bring your trust experts and inspiring conversation to help you navigate every step of the cancer journey. Today, I am joined by an outstanding physician assistant specializing in breast cancer surgery. From the moment a patient hears the words "you have breast cancer," through surgery and recovery, PAs are an essential part of the care team, providing education, guidance, and compassionate support. In this episode, we will discuss what patients can expect before and after surgery, common misconceptions, recovery tips, and how a multidisciplinary approach can improve outcomes of quality of life. Let's dive into this important conversation and welcome to the show Cecilia Hampson. And she is a physician assistant with the University of Florida Department of Surgery. She obtained her bachelor's degree from Gordon College in Wenham, Massachusetts, and obtained her master's degree from Northeastern University in Boston. She completed her general surgery PA fellowship from the University of Florida here in Gainesville, and her clinical focus includes the surgical care of breast cancer, benign breast conditions, the evaluation and management of high-risk breast cancer patients, and overall breast health. Her goal is to educate and empower patients to better understand their health so they can take an active role in their care. Outside of work, she enjoys reading, traveling, and experimenting in the kitchen. Most of all, she values spending meaningful time with her husband and her 2 children. So, Cecilia, thank you so much for being with me today.
Thank you for having me, Darlie.
Absolutely. So can you tell us about your journey to become a physician assistant specializing in breast cancer surgery?
Absolutely. So my journey really began in a very unusual way. I knew I wanted to practice medicine, but I wasn't sure in what capacity. And so when I went to college, I studied political science and French. And I also, essentially, when I graduated, worked in private sector initially with nonprofits, and then I delved into the startup world for some time before I transitioned and wanted to go back and pursue a career as a PA. So after graduating from PA school, I knew I wanted to pursue a career in surgery, even though it was kind of when I first started PA school, I remember telling a good friend of mine, I'm not interested in surgery because the hours are ridiculous, and I it's not for me. It's not for me. It's not my cup of tea. Also, I don't like the attitude that I see in like the OR. And I think God played a funny trick on me, because as soon as I popped my head in the OR as a student, I realized, you know what? Darn it, I like it. So after that, I wanted to definitely hone in my skill, earn the skill set essentially, so that I could feel competent and ready to practice in this particular and very demanding, field of medicine. So I completed a fellowship here at UF. It was a fantastic experience. It was a harrowing experience because you're basically plucked and from department to department. If one time you're in vascular, then you're in ENT, then you're in cardiothoracic, then you're in plastics. But as I made my way through every department, learning technique, learning management of patients, learning disease processes, I just fell more and more in love with surgery until I found my home in breast oncology, meeting Dr. Spiegel, the team there, and the patient population. It just felt like a perfect fit. It was the right size for me. And I enjoy my work. I love working with the patients. I love being able to take the time to educate patients, to come alongside them as they make, lifestyle changes to improve their risk, as well as to improve their post-surgical, treatment. And so that's kind of in brief, like how I ended up where I am.
Which I'm so glad, Cecilia. Has been amazing having you in the team.
I love it.
I think patients really speak very highly of you. It's really nice to see. I think that we are in this role or working with this type of population, and I don't think that I have met anybody who is in this field and is not passionate about it. And we just want
Absolutely.
to love it the way we love it. So that's really great, has been to be working with you. So many people don't realize the important role of physician assistant play in cancer care. Can you describe your role throughout a patient's surgical journey?
Absolutely. And I would agree that, it is an important role. And I think it's mainly because oftentimes I'm actually the first person who ends up calling the patient to, deliver the news that they do have a cancer. But even though that it can be very challenging emotionally, one of the things that I do find joy in is being able to convey, hey, you have a really good team here. We're going to give you the best possible care, and we're going to hold your hand while we do this, while we take this journey. So again, it can be very challenging to deliver that news. But I think one of the big things that I think PAs bring into any field really, but in particular mine, is the ability to take the time to pause and wait to hear, did you understand that? Did that make sense? How can we help you right now? Are there any other needs that maybe we haven't talked about? For example, are you worried about cost? Are you worried about transportation? And so as an initiator, when from the moment that I call that patient, that's when their treatment begins in a way, because we're making sure that they get all the resources that they need to get them through that journey. Then afterwards, I do see them in clinic. Occasionally, I am the one who will evaluate them in clinic when they come in with a lesion that they're not sure what it is. We punch biopsy it in clinic, and now we have a diagnosis, and we can take them to the next step. I also help in the operating room, and I first assist with Dr. Spiegel. And in that case, my main role there is to make sure that every step of the way, the correct management is being done, closure of the incisions when completed, post-operative care, and basically explanation of how to take care of your wounds or drains or whatever it might be. And then afterwards, I am their surveillance person. So I make sure that at 8 months and at 2 years that they are progressing appropriately, that they're getting the resources that they need, that they're seeing you, Durley, and your team. So, I make sure that they have all the extras that they're going to need to make sure that they feel comfortable, that they're sleeping, that they're eating correctly, that they're exercising. And so that, I think, is one of the things that I delight in my job too, because I am seeing from beginning to end someone through their treatment. So it's very satisfying, and I love my work.
Okay. And how has breast cancer surgery evolved over the past decade?
There's been such a huge change in surgery for breast. We went from radical mastectomies for everyone, which means we're taking breast, we're taking muscle, we're taking level 1, level 2 lymph nodes. I mean, that is a lot of surgery and a lot of morbidity there. But we've gone from there to reducing surgery as much as we can. So if we can avoid taking lymph nodes, we will. If we can avoid taking all of the whole breast, we will. We will save and conserve the breast as much as we can. And, every person's different. I always tell patients that, every cancer diagnosis is almost basically like a thumbprint. They're all so different, and the management of each is going to be individualized to that person's anatomy and their, the biology of the cancer, as well as their age and stage in life. But I would say that breast cancer care has become more specialized. We tailor to the person's needs, as well as the type of cancer that they have. And in addition to that, we've now even begun using robots during intraoperative surgery. And a lot of patients, I think, don't realize that although the robot has been it's been around for some time. It's only until recently that we've now been allowed by the FDA to use robots in the OR for these types of procedures, which is fantastic.
Yes, I know. We are so excited. It's
Yeah,
like a new toy in a way. So
it is definitely a new toy.
actually, I saw the one of the first post-ups. That was great. That was a really great outcome. I was really,
Amazing.
really
Yeah, they
pleased.
look fabulous. And one of the big things I will say about why are we offering robotic surgery? It's not just, the novelty, but the main reason we've brought it to UF is because we want to make sure that we can offer the best of the best to our patients. And one of the most promising things from early data that we've seen so far is that there is some level of sensation that people retain after using the robot versus an open nipple sparing mastectomy, which is so exciting. Game changer. It's an absolute game changer. We want to be able to give people their lives back as much as possible after a diagnosis as scary as cancer.
You're right. And I had a patient years back that told me, why should I want to keep nipples if when my husband touched me, I cannot even feel it? What's the point of that? Which that really kind of like stick to my brain. Like, you know what? You have a really good point. And yeah, they're there, they look great, but I don't feel anything. So what's the point? And then I'm like, wow, that's a good way to put it. So I'm sure that if she know, like, I don't know if she knows yet. I don't think so. That now you guys are doing this kind of robotic surgery for that sensation. So that's amazing. So excited
Yes,
about that.
very much so.
What factors determine whether a patient is candidate for breast conserving surgery versus mastectomy?
That's a good question. So there are a lot of factors that we take into account when making that decision. And ultimately, I would say for the most part, it's always going to be a joint decision. I will tell you the majority of our patients will come in, and of course, a cancer diagnosis is very scary. And we try as humans to control as much as we can, given information we have, right? And so often we have patients coming in and their first reaction is, I want them both off. I want both breasts off. I don't want to have to deal with the risk of having them anymore. And so, often we feel very much like we have to walk people back from the ledge. You know what I mean? Like, you know what? In your case, we actually can conserve your breast safely, which is super exciting. And so there are a lot of conversations like that we have. But typically, what we are really looking at is, first of all, what is the size of the mass? Are there lymph nodes that are biopsy proven to be positive? Are there, how extensive is the disease? Because sometimes you can have a woman who will come in and their breast initially, we found an area that was biopsied and cancer, there's definitely cancer in there. But then when they undergo MRI evaluation, we realize actually there are more areas here that look suspicious. So that can be challenging as we gather information, because sometimes when we see patients in clinic, their workup may not have been completed yet, right? And so there's always a back and forth about what the plan is based on once we have all the information. Typically, when a patient comes in, they will at least have a mammogram and a biopsy completed, plus or minus an MRI. After going MRI evaluation, sometimes additional biopsies are recommended for further evaluation of extent of disease. And so all of those things will play a role in terms of how much tissue is recommended that we remove. However, I would say the majority of patients do qualify for breast conservation. And in those scenarios, we often try to, we favor that option for patients. And I think one of the big things to know about that is that there's a lot of complications that can occur, life-altering changes that can happen after removing the breast completely, which is hard to understand when you just receive that diagnosis, right?
That's correct. Yeah.
Yeah. But the reality is that there are so many wonderful options that we can offer our patients. If they are, there are a lot of factors like genetic mutations that we also take into account. So even if maybe the extent of the disease is not significant, if they are a BRCA1 carrier or another pathogenic mutation, that increases their lifetime risk significantly. In those scenarios, we definitely have a conversation about prophylactic mastectomies. Exactly. And that's, again, just for that person in particular. It is a factor that it will affect the quality of life long term. So it makes more sense in that scenario. The scales are, weighed up, and they're leaning towards benefit here in terms of removing both breasts, but not everyone's the same. And approximately only about 25 to 30% of those cancers are actually pathogenic mutation cancers, so those are probably the biggest factors when trying to determine what kind of surgery the person qualifies for. The other big thing that people forget is just the proximity of the cancer to the skin. That's a big one, because sometimes patients want to undergo, for example, like a nipple sparing mastectomy, and they would like to be able to keep their nipple or an areolar complex. However, when the mass is perhaps too close to the nipple or too close to the skin, we have to be able to take the skin and the nipple, because it can the recurrence is our concern in that scenario. We don't want that cancer to come back. We want to be able to give you the best oncologic surgical procedure possible, the safest one. And so in those scenarios, we would have that conversation with the patient.
Are you guys still doing prophylactic at the same time of the surgery? Like, I know it was a time when we were doing it, and then was a time that we kind of stopped because we were having more trouble sometimes with the prophylactic versus the therapeutic. So I know that there was a point that with Lisa was doing more the therapeutic mastectomy and then just waiting for the prophylactic, what the breast reconstruction was coming later. Is that still the case? Or because I think I have seen more bilaterals lately.
Yeah, that's a really good question. And again, this is just the same conversation we just had, which is that there's a lot of factors that go into making these decisions. Patients who are a little bit more high risk, surgical high risks, for example, they're slightly more likely to have complications from the procedure itself. In those scenarios, sometimes we will have the patient wait a full calendar year before we can go back to the operating room. For example, patients who are overweight, obese, morbidly obese, patients who have diabetes, patients who are already immunocompromised. There are a lot of patients in those scenarios where, it's just not safe. And the main reason for delaying the prophylactic side is because in the scenario where we did both, and that prophylactic side becomes infected, or there's a hematoma, there's some kind of surgical complication, it will delay that patient's care, particularly with radiation, if recommended, or any other oncologic, treatment plan. And so that's why in some scenarios we don't offer the prophylactic right away. It's not a hard no, it's just a hold on,
That makes sense. Yeah.
Yeah, the other big reason where we will delay a prophylactic mastectomy is when we are dealing with a very aggressive cancer. This patient has perhaps a triple negative or a triple positive or extensive disease that has nodal involvement. And in those scenarios, we know that the patient will likely need neoadjuvant chemotherapy, possibly adjuvant chemotherapy, probably radiation despite mastectomy. And so in those scenarios, yet again, we don't want to delay any of that care and compromise that side because we're doing a prophylactic too.
Okay, that makes totally sense. Thank you for clarifying that.
Yeah.
You mentioned robotic before, so will you explain to the audience how robotic surgery differ from traditional surgical techniques? So I know it's a robot in there, but what is specifically make a difference?
So that's a great question. Aside from the sensation that we were talking about just now, which again is probably the greatest driver that led Dr. Spiegel and myself to adopt this new technique here at UF. The other big thing to note is that when we are doing nipple sparing mastectomies, they are incredibly challenging procedures. And mainly that's because we're often taking the full breast via a very small incision, sometimes at the IMF, the inferior, that inferior fold under that woman's breast, sometimes in the axilla, sometimes it's, it may be a radial incision. And so these are very challenging procedures to do open, because it means that there's going to be a team required, people that will need to be holding the tissue up. The surgeon is basically operating in a very tiny hole. That visualization is very, very challenging. And I would say this is probably the most advanced technique, perhaps only after LV bypass, that we offer here at UF. So it's a very challenging case. However, one of the most wonderful benefits of doing a robotic nipple sparing mastectomy is that the visualization and exposure is incredible.
Okay.
It's an absolutely incredible way of being able to visualize the tissue without having to have, you just need a team of two. That's all you need. And no one's really holding anything. The robot is taking care of that, giving us exposure. So, in a lot of ways, it's actually a lot safer to be able to have the robot because the robot hands are actually incredibly gentle. Often, when we are doing this procedure open, because of the exposure is very challenging, when there is a bleed that happens, it can sometimes be very difficult to get to the right vessel, to clip it correctly, or to cauterize the area appropriately. Whereas with the robot, you have this amazing exposure and can often avoid
Yeah.
hitting the larger vessels because you can visualize so well.
Okay.
One of the biggest things that I've seen in terms of the challenging this robot is that there isn't enough data out there right now to prove that it is an oncologically safe way of doing a mastectomy. As in, the fear is that recurrence, because not enough tissue is taken, recurrence can be an issue. But so far, the trials that have come out of Italy, because in Italy it was where the nipple sparing mastectomy with the single port robot was started.
Okay.
The data actually does not show that at all. It shows equivalent or better than open, which is fantastic. With the benefit, like we talked about, which feels it's a safer, it is preservation of sensation. So there's a lot of perks to it. There is perhaps if I were to criticize one thing, it's the length of time, and it's truly dependent on the team you have. So if you have a team that knows what they're doing, they know how to drape the machine, they know how to dock the port, they know how to take care of any small things that might come up. It's actually quite efficient. But in general, open is still faster right now.
Okay. Okay. Very good. Well, this is exciting, and hopefully we get to see. I know that right now is a certain criterion for it, right? So
For
has to
sure.
be a certain size for the cancer, certain size of breast.
Yes.
So I know that you guys are kind of having to beginning with, let's kind of start with this a little bit more simple, and then hopefully move into just be able to offer to everyone, depending if they're a candidate of no, of course, for it.
That's right. Exactly. Exactly. And all those same limitations that we spoke of before are still apply. The only additional things that we need to take into consideration with a robot or truly any nipple sparing mastectomy is, why are we doing this? Because we're taking the breast tissue for oncologic care or prophylaxis, but we're also planning to put an implant or an expander in. So whenever someone is undergoing any elective surgery with plastic surgery, you need to take into account certain things. For example, we cannot have a smoker. If you are an active nicotine user, we cannot operate on you until you quit for at least a few months to be safe. The other big cutoff is a BMI, and that's now true for the robot as well, because again, we're working closely with our plastic surgery colleagues who are doing an elective procedure. And so they need to feel like, yes, this patient is not going to be high risk for postoperative complications.
Yeah.
And unfortunately, high BMI is a risk factor. The other big thing, and this is again due to the limitations of reconstruction, the patient cannot have significant ptosis, which is basically the fall of the breast over time. As the nipple droops down, that's what we would call ptosis. And so we cannot have a candidate with too much ptosis present. Yeah, it would be incompatible. We'd have to do a different procedure for that.
Okay.
But yeah, those are the main things. Those are essentially the main things that we worry about. We want to make sure that's the correct candidate.
Okay, perfect. You mentioned something that made me think of another question that sometimes I realize patients are not being told, and not because when they come straight in our team from the beginning, you guys do an amazing job explaining in detail all the options. But sometimes we get second opinions, and sometimes we just not necessarily, we get in here MPT referrals from outside the system, and
Oh
they
yeah.
come in, and then patients who come post-surgery with mastectomies, never saw plastics, and they yet still wanted to do implants. And like, did you ever saw plastic surgery before? Did they ever ask you
Wow.
one? And it's amazing how they done. So would you explain a little bit to the audience out there, like, why is that so important for you to know? If you're gonna have a mastectomy, you need to know in your head, what do you want to do? It's not like, yes, I want to do reconstruction, but then change your mind at the end and say, no, I don't want it, or I don't want it, and all of a sudden, no, I do want it, because I know the surgical plan is totally different one versus the other.
Yeah. So I would say that that's a good question. And it makes me a little sad to hear that sometimes patients are not really getting that. They're not even having a consultation to have that option, because that doesn't feel right, doesn't feel fair. Often, I would say we can always, for the most part, offer reconstruction unless there's some like significant health comorbidity that we are worried about. For example, if there's a like significant cardiac history or uncontrolled diabetes, in those scenarios, obviously we may not be able to, or maybe advanced stage even. But I would say for the most part, reconstruction is always an option for sure. It's an important thing that is vital to be able to offer to patients, because like I said before, we want to make sure that even though cancer is very scary, that we're not just removing the cancer, but that we're giving this woman her life back, that we can bring her back to whatever she was doing beforehand. And often that does involve some level of reconstruction. It's an important thing. And I have patients come in sometimes and they're like, it's too vain. I don't really want to worry about it right now. I just want to be safe. It's not vanity. The way we perceive ourselves in front of the mirror, in front of our spouses, in front of the world, it's important. There's a lot of significant social emotional changes that happen after, for example, a mastectomy.
Absolutely.
Yeah. And so I would say that plastic surgeons here at UF play a very important role in the care of these breast cancer patients. I would say that even in a delayed fashion, reconstruction is still possible. So even if those patients have undergone a simple mastectomy, they don't have an aboreular complex, there's no implant in there, we can actually bring them into consultation with a plastic surgeon. Typically, with a flat closure, we would offer a tissue expander first. So the tissue expander would be set in place. And for those who don't know what that is, it's essentially it's a kind of like a flat implant in a way that slowly gets filled over over an extended period of time. Most often they're filling it with saline, and it's the filling is done in clinic by DAs or your surgeon. And that gradual increase in volume essentially is creating a pocket in that chest wall that will ultimately become the pocket that is used for your implant, whether it be saline or gel. Now, delayed reconstruction results sometimes are a little bit more limited than if you do an immediate reconstruction. But it's still, I would say, something that is absolutely viable and worthwhile pursuing. Often, even after you've had the implant placed, in order to give you appropriate contour and silhouette to the breast and make you as symmetric as possible to the other side, your surgeon might recommend a contralateral mastopexy, which is when they basically do a little breast lift or a little reduction on the other side to match the reconstructed side. And often, in order to make the shape more natural, they may recommend fat grafting, which is when they take belly fat, and patients always get very excited when they hear this.
Yes.
Little lipo, yes, on the belly. And then we take that belly fat and we actually put it in your breast. And to even make it more interesting, sometimes if the patient, again, is a good candidate, we can offer something called a DIEP, or a deep inferior epigastric perforator flap. And in those scenarios, the plastic surgeon is essentially taking belly muscle and belly fat and putting that into the chest wall and reconstructing the breast with your own tissue. So it's an autologous reconstruction. It's a wonderful way of creating a reconstruction, especially for patients who, for whatever reason, the implant was a problem, or just don't want an implant. They just want their own tissue.
Okay.
But of course, in that scenario, patients need to be able to have a little bit of belly fat. Some patients just don't have that. And so the deep is not possible.
Okay, perfect. Yes, so yeah, interesting. So they'll have to, if they have a complete mastectomy, no expanders, the option is still bringing them back to surgery, put the expander on, and then later on, hopefully, change that into an implant. How about radiation, though? If they have radiation, that's not an option, right?
That's a good question. No, you can still get a deep. So that is still
Yeah.
possible.
Yeah, for an urologist, yeah, but not for an implant anyway.
Not for implant, probably not. And especially if you've received like proton therapy or extensive adjuvant radiation. Yeah.
Okay,
Yeah.
perfect. So How can patients best prepare physically and emotionally before breast cancer surgery?
So I think that is really important. Whenever I first encounter, again, one of those phone calls or when we're in clinic, when I encounter patients for the first time, I always recommend that if you have a family member or even a friend, a neighbor, someone, bring that person with you to clinic. Because one of the biggest things that I find, no matter how much you try to prepare for that visit, it can be very overwhelming. You're getting so much information all at once. So having a second pair of ears is really important. But I always say too that in order to be emotionally prepared for this journey, you do need the support of a community. And I understand that sometimes patients don't have that. And that can be very, very challenging when a person is isolated. In those scenarios, I often do recommend that they see OT and that they see psychology and that they see basically some of our team members, really, that can really help patients kind of guide them through the emotions that they're having, the very valid anxiety that they're feeling, the very valid depression that they might be feeling, and have someone that is actively listening. That's really important. It's tough because everyone's response is different. I have encountered all sorts of responses in clinic, patients who maybe they're not emotionally ready yet to accept the reality of this diagnosis, right? And so we work with you. We work with you to make sure that we can bring down any barriers that are kind of making it challenging to ask for help or to get the treatment that's necessary. And then I have other patients who bring their binders and they've done their research. Yeah. They know exactly what they want. And in those patients, what we do is we offer them as many resources as they would like, because they already know what they want and what they need, and we are just going to support that. So honestly, there's such a variety to the reactions that we get in clinic. But regardless, just know that the treatment team here is going to take good care of you. There's such a great team that we have, Durley. I mean, everyone that these patients encounter really cares. They really care about outcomes in this patient's lives. They care about the patients themselves. So it's really part of the reason why I love my job, actually.
Yeah.
Yeah.
How about the physical standpoint?
From a physical standpoint, if you are not exercising, it is time to get started. If you are eating junk, it is time to start eating better. The earlier, the better, especially if you're going to need chemo, especially if you're going to be doing a bigger surgery. Like, a mastectomy, especially if you're anticipating radiation. All of these treatments you're going to have much better outcomes if you put in the hard work. It's hard though, because it can be very, sometimes these diagnoses, they're so challenging to accept that it can sap your energy. You know what I mean? And so that's where your family members come in. That's where your community should be supporting. And asking for that kind of help is totally appropriate. And I always highly recommend it. But yes, absolutely. The more you can do now, the better. I'm like, it's time. Let's go. It's time to get started on moving. I'm going to keep you accountable. When you come back to see me in clinic, I'm going to bug you about this. So I really need you to at least start doing a day, 1 or 2 days a week where you're exercising. But it's really, really important. Absolutely. And I'm sure you do too, Darlie. I've definitely heard some patients saying like, Darlie, it's so excited that I'm swimming or that I'm doing X. I know you're cheerleading over there too.
So we actually do part of the Resona pre-op. So for the audience that maybe is new to the podcast and have not heard me saying this, but we have an amazing surveillance program where we actually try to see almost, if we can see 100% of the patients before surgery, we will. So we have a baseline measures, not just to make sure they don't develop lymphedema. And if they do, we can actually work on it early on to be able to reverse it, but as well look into range of motion, strength, any other deficits overall that they can start to work right away. So we see patients, you guys see them for the consult, they get the diagnosis, and within 2 weeks, 3 weeks, we are seeing them here in the clinic. So they are still kind of in shock and emotionally stressed because the waiting time is the worst time, because it's like waiting on the path report, waiting on surgical day, waiting and waiting and waiting. So it's hard. That's no easy piece. But in that visit, we do a body composition where we actually talk about this, right? Like, what is your body fat mass? What is your skeletal mass? What is your habits? Like, how do we need to start to improve this? Because depending where they're at, it's going to be great and it's going to help them to recover faster from surgery.
Exactly.
Or on the other hand, it's going to hold them back and it's going to create trouble. So, yeah, so they come in and it's like you're not exercising and look how bad your skeletal muscle is. So, you don't know yet when surgery is going to be, and more likely, if you don't know yet, it's not going to happen in 2 weeks. So, waiting for. You need to start tomorrow to start doing your
Exactly.
stuff and start working and doing these things. And we try to give them like overall, exercise guidelines. If we have the time, we can give them some exercises, but start to really work on it. So, and then every time they come for surveillance, we're doing a body compositions. It's fun because some of them are like, oh, you're going to be so mad at me. I hate you. I'm doing this just thinking about this test, but I hate to exercise. And when they see the results and they see how much fat they lose, how much muscle they gain, they're like, oh my God, actually it's working. And they get excited even though they hate it, but they know it's good for them and they feel better.
Absolutely.
So we have
Absolutely.
a conversation about really start working on it. And then I'm trying to really go a little bit more in depth in nutrition. So it's important for them, like you're going to go to a process of inflammation because you're going to have surgery.
Mhm.
So what can you do to bring down your inflammation process? So you need to do an anti-inflammatory diet, right?
Yes.
So just make sure that you start to modify that now. Don't wait until you have a day for surgery and you start being good at that few days before that. Start now. So I always
Yes.
tell my patients, like, I don't think I have met pretty much any patient who unfortunately had a cancer diagnosis and then become healthier. So I always say, why are we waiting on this instead of taking care of our bodies? Because perhaps for not taking care of our bodies is how we end up with this cancer diagnosis. Because we know it's not just related. I mean, you can have a gene and
Yes.
that's totally valid, but not necessarily everyone who has a gene develop the cancer, right? So definitely
Exactly.
factors out there, and is how are you treating your body, right? Are you eating right? Are you exercising? Are you doing well with your taking care of your mental health? Are you sleeping well? How are your stress levels? All these parts of the puzzle are so important to come together. So we cannot go over all this with patients in the initial visit. So it's not really about just we're going to do measurements for lymphedema. And I know that's usually where they cannot get engaged, but it is way beyond. Like, the lymphedema part is just a little piece of it, but really having them, educating them, and reinforcing what you guys has been explaining, kind of telling them, yeah, after a mastectomy, this is what you expected. This is going to be your precautions. This is what
Yes.
plastic surgery it wants to be doing, but they're going to go more specific in what kind of restrictions or they're going to do for how long. But we kind of like, again, hold their hand and then tell them, no, we're going to see you 2 weeks after surgery and we're going to support you. And sometimes we see them before you actually guys see them post-op. And sometimes it's situations that are happening and we are the ones who are reaching out to you guys like, hey, I'm thinking this is an infection going on in here, or I think something else is
Yes.
here that is important to address. So again, I'm so fortunately as well to have a team like you guys and the surgeons who trust so much in us that we, it's not like we bug you, but we know you guys know that when we text you and we reach out, is because
Yes.
something is odd. And so it's nice to know that we are kind of part of it. And know it's just like, that's kind of like PT at the end, but how important it is from the beginning.
No, you guys are fully integrated. I absolutely agree. I mean, it's a very important, and I will say one of the big things is this is particularly true of patients who've undergone mastectomy. I always tell them PT, they're going to be your long-term friends. There are times where maybe you're doing great right now, but in 6 months that might change. In 2 years, in 3 years, you might need to go back to PT. You might need to go back to work with early, and so they understand that. And I think that it's an important thing for them to kind of compute, right? Like this is a long-term relationship that I have with my physical therapist.
Yeah, that's true. I always tell them we'll be good friends for the next 5 years.
Yes, exactly.
Like me, it's some other PTs you can work with as well. So don't feel obligated. How can patients reduce the risk of developing lymphedema?
So that's a great question and related to what we were just talking about. So the body, the lymphatic channels that we have in our body I think when we do the lymphatic mapping prior to an LVB, you can really see how those channels move or don't move. I would say that some risk factors for lymphedema are definitely elevated BMI. So the heavier you are, the riskier it is when we're doing a sentinel lymph node biopsy or an axillary dissection, because we know that lymphedema might develop more likely in a patient who has an elevated BMI or who smokes or who's not exercising. Exercise actually does help those lymphatic channels move. You're promoting that movement. When as you're pumping muscles, those lymphatic channels are more likely to have more appropriate flow. Whereas if you're a little bit more sedentary, the risk of lymphedema goes up again. So it's really important to, like we talked about just now, to manage weight, both with an appropriate diet and exercise. And that does, in fact, reduce lymphedema risk. I've seen plenty of patients who have, again, an appropriate BMI who have unfortunately needed to go through with an axillary dissection and lymphovenous bypass and never do develop lymphedema. They just, their BMI is great and they're exercising and they're active. And so it is very telling when I see that. We know that exercise really, truly helps, and keeping an appropriate weight really, truly helps. So I would say those are the big things to keep in mind. And we do mention this when we're in clinic. And so one of the big things we talk about with patients is trying to decrease BMI a little bit before surgery, and it helps.
Okay. You mentioned an LV bypass or an lymph.
Yes.
Will you explain to the audience what is that? And again, we have the fortune, because I don't think that many institutions do, to is our standard of care, right? When you guys do an axillary dissection, the patients actually have the opportunity to have a lymphovenous bypass by Dr. Spiegel. So will you just kind of explain to the audience exactly what that means?
Absolutely. So you're correct, Early. Not all institutions offer this. So it is really exciting to be able, yet again, to offer something to our UF patients who can, take advantage of this procedure. Essentially, what we're doing when we are doing an axillary dissection, is we are removing level 1 and level 2 of the lymph nodes in the axilla on that side of the cancer. And that is because there was cancer in the lymph nodes when we initially the patient underwent a sentinel lymph node biopsy. So in that sampling, we found that 1 or 2 or more lymph nodes were positive. And so the appropriate response is to go ahead and take those nodes. But obviously, that's going to put the patient at risk for lymphedema. And so what we do is after we've completed the dissection portion of the case, we will isolate the lymphatic channels that are amenable, that are alive, that are draining into the axilla. And then we also isolate 1 or 2 vessels that look appropriate. And the main thing that we are looking for a competent vessel is that there's not any back bleeding. And so if the vessel is competent, the vessel is of appropriate length, then we go ahead and we actually reattach that vessel into the lymphatic channels that we have isolated. And we do this under the microscope. It is meticulous work. It is technically very challenging, but there is significant risk reduction by doing this procedure, about 30%. So it's worthwhile trying. So we always try. And in some patients, we are able to find a great vessel. In other patients, they may not have appropriate vessels. And so we wouldn't know until we undergo with the procedure itself. But I would say for the most part, we are able to often find a good vessel and reattach that. And that's what a lymphovenous bypass is. It's great. It's a great procedure.
Yeah. And that has been amazing. And we've been doing this already for a while. And not only that, but something as well that I'm really excited. We know, like in the lymphedema world, now is people, I think the only institution perhaps is doing that is, of course, Dr. Sinho Lab in Beth, Israel, like MLD with ICG. So in other words, they do like ICG, and then you can then do your manual lymphatic drainage, seeing the path and seeing where the fluid goes, which is amazing. And hopefully
It is awesome.
our goal, right? That's what we would like to do here at one point, but we're doing a little baby step of that with actually Dr. Spiegel takes the time to actually map those lymphatics and
Yes.
pictures and put it on the media. So we don't have a exact direct thing how it's working, but at least we know where those pads are. And what we thought for years were our pads, that is not true. And Australians discovered that like maybe about 4 years, 5 years ago, where like, nope, this is not the direction we thought these lymphatics were going. So has been super excited to see. And right now we're doing an MLD trial, which is manual
We
lymphatic,
are, yes, yes,
manual lymphatic
which
drainage
is very exciting.
trial to see, are we doing the traditional versus are we just really following these paths to see which patients actually develop lymphedema versus not. So it's exciting. I think we just start doing the trial this year. So hopefully
Mhm.
continue recruiting patients and see some good outcomes out of that. But that has been super great because really changed the management of lymphedema. Where I learned
Yes.
many years ago in how to do this really is like, not really. This is not how this works. So that has been really great as well, besides the LV bypass.
Agreed, absolutely. Yes. In fact, that's one of my favorite portions of this case because when we're mapping these channels, you can really see, you're literally seeing the ICG moving on that arm. And you can see whether that person has really great drainage and it's spontaneous versus, well, a person needs a little bit of massage to get that drainage going. So it is fascinating to watch. I never get bored.
No, I'm sure you would not. So for the last thing to let you go, I know you have a long day out of surgery, but what innovations in breast cancer surgery are you most excited about, and where do you see breast cancer surgery heading over the next 5 to 10 years?
Yeah, I think we've already talked a little bit about robotic surgery. I think that has been a very exciting additional tool that we are now using in breast oncology world. It is limited right now, but my thought is that most likely over an extended period of time, we will be able to start seeing it more frequently in multiple institutions. I think that's a very exciting thing, mainly because, again, it is providing patients something that we couldn't give before, which is sensation. I think the other big thing to note is that as research continues and as research start to roll in but with several studies that we've been waiting on, there could continue to be de-escalation of the amount of surgery that we end up doing in the first place. So that to me is exciting because even though I love doing surgery and I love doing these procedures, I ultimately would love to be able to see patients have less morbidity over time, because these procedures, they are wonderful because they're giving patients they're ensuring that they have controlled management of their cancer, but it is challenging in some scenarios. They come with risks. Everything that we offer our patients comes with risks, whether it be surgery or chemo or radiation. But we always weigh things. What is the benefit? What is the risk? And when there's enough benefit, we have to offer it. And surgery is one of those things. It comes with risks, but I think that's probably where I see surgery moving forward. Just de-escalation. Maybe we won't be doing sentinel lymph node biopsies in the near future. I don't know, but we will see what the data shows us, and we will follow guidelines accordingly.
Yeah, and actually, you guys are has been so many cases with no notes because
Yes.
that has been coming out. So it's really neat to see because again, I remember Dr. Spiegel always say every time we've been going over presentations, it's like, I'm the one that caused lymphedema. I'm clear. I'm the one who is taking the lymph nodes out. So it's nice for her not to have that responsibility anymore.
Yes, exactly.
So it's really great to see that happen to already. Like, a lot of I've seen more and more of like, no,
Yes.
so
When we can avoid taking them, we do. And I agree, it is great. I love being able to say, hey, we don't have to take notes. And that patient doesn't have a risk of lymphedema in that arm at all. It is great.
yeah, because it's one of the things as well that many patients, again, the cancer diagnosis is scary, but some patients are even more scary to develop lymphedema. Some of them are
Oh, that is true. That is very true.
terrified of it because they either have a family member or somebody who they know that they saw dealing with that and it's a lifetime something to deal with. So sometimes that's what scared them the most out of all of it. So it's nice to see that could be an option if that's where, what they kind of pretty much are a candidate is for avoiding that, depending on what kind of cancer and so forth.
Yes.
So Cecilia, that has been an amazing conversation. Thank you so much for being here with me today. I really enjoyed this.
I did as well. Thank you so much for having me, Turley. Absolute pleasure.
Thank you and have a great evening.
You too.
Okay, see you later.
Bye.
The information provided on this podcast for educational purposes only and is no intent nor should be used as a substitute for medical advice. Consult a licensed qualified medical physician for any issues concerning your health. Thank you so much for listening to the latest episode of Taking Charge of My Cancer podcast. If you have not already, feel free to share this with more people so they can benefit from this information. If you would like to connect with me, see the information on the podcast description. See you later.